I think we're ready to go.
Okay.
Do you have
Well,
an
thank you all
introduction
for
you wanted to give,
having me. I'm sorry.
I didn't know whether Carolyn was going to give you a little introduction.
Oh,
Andy,
that
from your
would be
bio.
great. Sure.
Perfect. All right. Thank you everybody for joining us today for this Lunch and Learn opportunity. We have Dr. Andrew Howard here, who's going to be talking with all of us about the increasing organ transplant access model that is coming our way shortly. So to go ahead and get started due to limited time, I will pass it over to Dr. Howard to begin.
Okay. Thank you very much. What we'll do is we'll go through this model. I put about 12 slides in I wanted all of you to have because it's extensive background that was provided by CMS in the proposed rule. It's really quite excellent. It goes on for about 75, 100 pages out of 400 pages. And it's all about the transplant ecosystem, much of which you know. So I will sort of very quickly go over those slides, but if there are questions, we can go back to those at the end. I want to keep track of time to finish in no more than 30 minutes so I can save time for ample questions. So this rule was released back in May, and with every CMS rule, they allow roughly 60 days to comment, and that's why the July 16th is in there. For those of you who don't know the difference between a alternative payment model and an advanced alternative payment model, I apologize if you all do. The advanced alternative payment model has to incorporate shared risk, which this model doesn't. That would be taking on risk, if you will, full risk for all Medicare Part A and B spending. In our space, the ESCO model, the dialysis model, was the first model in the kidney world that did that. Now the KCC model, which we'll talk about in a little bit, also does that. And those allow a pathway out of MIPS, and they have built in this 5% macro bonus for all Medicare spending. The problem, of course, is that that bonus basically ended and is being paid this year for performance year 2022. Next year, Congress allowed 3.5%, and after that, it's basically done, and there's an adjustment to the Medicare physician fee schedule. So that's not even an option anymore. I won't read the quotes. You can see them for yourself. I took those right out of the rule. This is what Medicare believes about this model and what they want it to do. These are the 6 stated goals of the model. It'll be up to you to decide at the end of the presentation whether you believe the model can lead to fulfillment of these goals or not, but they're pretty clear about this. And this is what they want to do, from increasing use of deceased donors to identifying more living donors, improving quality of care throughout the entire process, improving care coordination and patient-centeredness, and increasing equity and access. I apologize if you don't know the acronym SDOH, Social Determinants of Health. And as with all Medicare payment models, irrespective of what area they're involved with, reducing Medicare expenditures. Very laudable goals. The question many have is whether the model has any chance of achievement. These are the background slides, and I won't go over these, but I wanted you to have them for your reference. And if Carolyn hasn't done it already, there's a PDF of the presentation that you'll all have, so you'll be able to have these. It's really I must credit them. I thought it was a terrific summary of all the data in our space, from this one, ESRD, to some of the transplant data, which you probably know quite well. The last bullet there, that's, of course, if you look at the OPTN metrics dashboard, that's looking at all kidneys, kidney and kidney pancreas. You can also query it for kidney alone. It's going to drop it by about 1,000 or so, a little less, 800. But you can see the numbers there. There's been little change in living donors. They use a term, transplant ecosystem, and they talk about it. We'll talk about OTAG briefly. This is the Organ Transplant Affinity Group. It was created 3 years ago. Vicki hears about this nonstop. Established by CMS and HRSA. I think this was a good idea because these two arms of HHS does give them an opportunity to work together. And really, it was OTAG that drove the model through CMMI. And you can see again what they intended to do with the model in the 6 bullets at the bottom of the slide. I know I'm moving quickly through this. They talk about all the different aspects of the model. I'm sure you all know about NOTA, the National Organ Transplant Act. That's what established OPTN. Since 1986 has had the contract, and SRTR provides all the statistical and analytic support. You all know well about the OPOs. We've got 56 now serving a donation service area. Organ acquisition costs, I'm sure you all know these well, but these are some of the main costs that are included and reimbursable through the Medicare cost report that are submitted. That's not my estimate of surgeons' fees. That's from the proposed rules. That's Medicare's. Again, key things about the donor hospitals, from the hospital condition for coverage and the dialysis facility condition for coverage, about obligations with respect to the transplant process and the ecosystem. The wait list, obviously it goes without saying, a patient must remain active. I think you all know that there's tremendous variability, but at any time, any given transplant center can have as many as 40 to 60% inactive on the list at that time. Patients can list at multiple hospitals. When I was in practice, I took advantage of this. I practiced before I relocated to the West Coast in the metropolitan DC area. So we had access to no less than 4 to 6 lists pretty quickly. And we encouraged our patients to go and list at 4 to 6 transplant centers. OPTN obviously maintains the national wait list, and I think you all know about changes to the kidney allocation system in 2014. They also summarize what Medicare Part A pays for. Again, this is their estimate. This is an important figure because you'll see that's where they got the positive payment adjustment. It's about a third of this, reimburses organ acquisition costs. And then this is what Medicare Part B does. And I think you're probably aware at this point, but if you're not, there was a key piece of legislation that was passed in 2021, which actually started a year ago. And this extends a goal for decades of all the kidney-related physician organizations and others, patient groups that wanted to extend Medicare coverage for immunosuppression beyond 36 months post-transplant. And this now is in effect. The regulation, I won't go through these, but I've summarized for you some key regulations going back 5 years. I think you're all well aware of the modernization effort and the act securing the U.S. Organ Procurement and Transplantation Act. It was passed last fall. And let's get to the rule. So this is supposed to be a 6-year rule. You can see in the bullet below, they talked about other options for this rule. And they invite comments on those other options, but they settled on starting January 1st, 2025 for 6 performant years. Kidney transplant hospitals will be eligible to participate with a focus on adult kidney transplants. You'll see more about this shortly. But they're going to be chosen based upon a selected DSA, and they're going for about 50%. Every eligible transplant hospital based on adult kidney transplants will have to participate if it's selected through the DSA. And they'll attribute patients both through the kidney transplant waitlist and recipients of kidney transplants. And there are 3 performance-based incentives, which we'll go over in some detail coming up. What they did, it's kind of complicated, but they broke the country into 8 census divisions, and they placed DSAs, this is an important point, into 2 mutually exclusive groups in each census division. Why did they do that? They were trying to be fair to look at larger transplant programs versus smaller transplant programs. I have heard from many individuals who've forgotten more than I know, and they're not buying that this is going to do that. And I know, Vicki, you've seen the comments in preparation from the forum, but there are several who believe that they're still going to miss the boat with this. But at least I wanted to credit them for trying. So I wanted you to know about this. If your transplant center is selected, you can opt out. If you're eligible, you have to be Medicare approved. Again, there's a focus on adult kidney transplants using 18 years old as the definition. You'll be compared to a baseline period that's going to last 36 months, ending 12 months prior to the start date. Very similar to the Kidney Care Choices model. And they say this is going to be a random sampling of DSAs, and they estimate about 90 out of 250 transplant hospitals are going to be chosen to participate. That's what Medicare thinks it'll be at the end. Again, via the wait list, patients can be listed at one or more of the IOTA transplant hospitals. They can be active or inactive for a transplant center to get credit. To get credit as a recipient of a transplant kidney, they must be alive and greater than 18 years old, and the transplant must be functioning. All payer types now, including Medicare Advantage and commercial, will be used for attribution. However, you'll see when I get to a later slide, in order to either get a positive or negative payment adjustment, it's only going to be patients with Medicare fee-for-service, primary or Medicare secondary payer. And there's going to be reconciliation at multiple steps, very similar to Kidney Care Choices and other models. They do go through great pains. These are their quotes. I took them right out of the proposed rule. They acknowledge that the mandatory dialysis model, the ESRD treatment choices or ETC, and I already mentioned the KCC models are ongoing, and they do not see these as problems. If transplant centers are participating, I'll show you the numbers coming up in these models, it's not going to prevent them from continuing to participate. They have a nice little infographic as part of the rule on the IOTA CMMI model website. You can easily Google that if you haven't already. And this goes over these three models. I wanted to show you some of my own thoughts. Interestingly, with the ETC model, including the ESRD Treatment Choices Learning Collaborative, almost all the OPOs and 181 of 250 transplant hospitals are participating in the ETCLC. It focuses on managing clinicians, which are primarily nephrologists and their advanced practice providers and dialysis facilities. You can see the model started in 2021, wraps up in June 2027. It's got a performance payment adjustment, which basically adjusts the dialysis payment, the MCP, and then the for the nephrologist, and the PPS payment for each dialysis treatment. And it focuses on home dialysis, transplant waitlisting, and only living donor kidney transplants. Through a different selection method, I won't go into this right now because I do want to focus on the IOTA rule, which is completely different. But these were hospital resource areas that they looked at for this. Bottom line, about 30% of the country got put in this model in terms of dialysis facilities and nephrology practices. The Kidney Care Choices model, full disclosure, I'm on the board for the Delmarva KCC, although I'm not getting any funds from this. My previous group that I retired from participated in ESCO and is now a KCC participant, and they asked me to stay on as a board member for them. The big twist I highlighted for you in the yellow bold, transplant providers, unlike the ESCO model, must be participating in this. And you can see there's a wide variety of types of transplant providers. Interestingly, of the 100 kidney care entities participating in this model as of the end of last year, there were only 10 transplant hospitals. There is a kidney transplant bonus that totals $15,000. However, the beneficiary has to have a transplant functioning for 3 years to get this. And this is a shared risk model. So you're responsible for all Part A and B costs for every aligned beneficiary. There are 3 payment adjustments. There's achievement, which basically is the number of kidney transplants performed. That's the majority of the points, 60. Then there's what they term efficiency. It's an organ offer acceptance. And quality, which is a graft survival equation, and 3 quality metrics I'll go over. There's an upside risk payment. It's a lump sum by CMS to the participant as long as the performance scores at least 60, and then there's a downside payment. That doesn't happen. You'll see more data about this until the end of the 2nd year. So what about this achievement domain? So this is the number of kidney transplants for attributed patients, and obviously it's to increase kidney transplants. I put some bullets in what the language they put in about trying to decrease unnecessary deceased donor discards and increasing living donors. Many feel that they don't do much to actually help increasing living donors in this. And then there is some controversy about how they're going to calculate the transplant target. There is, kudos to them, a health equity adjustment. So they'll take an attributed transplant, multiply it by 1.2 for low-income patients. If you don't know the acronyms, DE, dual eligibility, LIS, low-income subsidy, and I'm sure you know NLDAC, National Living Donor Assistance Center. In any case, there is controversy about how this is calculated, but I wanted to show you what they intend to do. This is just data for you to have if you want to see by each performance year how they're going to calculate the baseline years and what years they're going to use to trend this national growth rate. And you'll have this to go back to so you don't have to pick it out of the rule. This is pretty steep. If you just reach 100% of achievement, you're at the top of the peer group. You're only going to get half the points. You have to literally hit 150% or greater of achievement to earn the full 60 points. You'll see how the math all works out here. So what I really want to point out is this is a steep climb. Let's jump to efficiency. This is the organ offer acceptance ratio. This only gives 20 points, and of course, it's to increase access to kidney transplants. For comparison, they talk about OPTN's 2022, which has a threshold of about 0.3, accepting, about 30% of what's offered on the average. This looks at, for the numerator, number of acceptances over number of expected acceptances. Again, they point out in the rule they're not going to require transplant centers to utilize higher KDPI kidneys. That's up to the transplant center. And they also give a little push that if you're selected, you could decrease your expected acceptances by adding better filters. Just a list for you of included offers and excluded offers, so you'll be able to go back to this without picking through the rule. And again, as they've done with all their payment programs, Vicki knows this quite well from years of being involved, as others of you might with QIP. You can either score by achievement or improvement, but you'll always get more points with achievement. So this is how they're going to reward points in this domain for achievement. More typical, just 100%, unlike the transplant rate. This is not 150th percentile. And you can also score by improvement, but this can't happen until the third payment year. And basically, this is an all or none. Remember, with the other, you could get 20 points. Either you're going to get 12 points for improvement or you're going to get nothing. But they are giving you a way to increase points if you've shown improvement, but you haven't hit what you want to hit with achievement. And again, this is very typical. This is what they've done with every one of their quality payment programs. Moving over to quality, they've got one post-transplant outcome measure. It's a composite survival rate for grafts. It's unadjusted. It's basically the number of observed functioning grafts and the number of completed kidney transplants in adults as they define greater than 18 years old. And it'll be updated each payment year with cumulative unadjusted data. And you can see how you can score points here. Again, a lot of folks, I know I've seen many comments, have already had issues that they're not using adjusted data and they're not following what SRTR and UNOS actually does for this already. The three quality measures, there's a shared decision-making measure. I'll show you a little more about these. There's colorectal cancer screening, and then there's this care transition measure. They elected not to include the hospital CAP score, patient activation measure, or depression screening. Interestingly, the PAM and depression screening were and remain two of the KCC quality measures. And you can see the last bullet there. I capitalized the letters. If you're selected participant, you must report quality measure data to CMS. So there will be some work. One would hope they would set up a fairly easy way to do this. So what are the three quality measures in addition to the organ survival measure, the transplant survival that I showed you first? So there's this shared decision-making measure, and there are going to be three questions. And basically it's what's shown there. This is what it's after. This will be administered once per payment year. There's colorectal cancer screening. They're looking at 50 to 75-year-olds. They point out this is a universal foundation measure. It's part of their meaningful measure set, administered once for years. I've had many tell me, and you all know if you're transplant centers, that every transplant center does this. Interestingly, one of the forum members, I'll leave unnamed, felt this may have been tongue-in-cheek thrown in because this will be easy for centers to hit because everybody does it. But other people felt that this was a meaningless screen measure and there should be something else to replace it. And last but not least, there's this 3-item care transition measure. Again, this will be a patient-reported measure, and you can see in the second bullet, this is what it's after, these areas to try to assess. And this will also be administered once per payment year. If you're not familiar with these acronyms, this is what Medicare does in their quality payment programs. P4R is pay for reporting. So for payment years 1 and 2, you just report data. You don't have to perform. Payment year 3 and beyond is pay to perform. So you have to hit benchmarks in these. So again, this is how you score points in this measure. You can get a total of 8 points for collaborate in the care transition and 2 points for the colorectal cancer screening. Before I show you how it's calculated, I just wanted to give you this summary again, because I'm going to show you a hypothetical situation that's looking at this. Remember, to get 60 points for achievement, you have to be achieving 150%. And if you score 100% on the other two measures, you'll get your 20. So let's look. So for the upside risk payment, which they estimate will be about 20 to 40% of the participants per payment year, you must score at least 60. So I've shown you a hypothetical in the bolded yellow below. If you score 75 points, remember, that's a tough climb. I'm assuming here that you're going to score at 100% for the achievement or just above it, not 150%. And I'm assuming you're going to have to score at 100% for the other two measures. you'll end up with 300,000. As you drop off to, if you go down to 70 or 65, this falls off to 200,000 and then 100,000. So it can drop off pretty rapidly. If you're at 60, you're not going to get anything. For payment year one, anything less than 60 is going to be neutral. There's going to be no payment penalty. Then it'll be in this other range. And then there's the downside risk, which is designed to be much less. But you can also see, I've given you a hypothetical here. Let's just say that you've scored 30 points here, and then you'd be paying Medicare 25,000. Obviously, this falls off pretty quickly. And they are not looking to heavily penalize transplant centers here. They estimate about 10 to 20%. If you look at their estimates, they think that they're going to be paying about $36 million over the 6 years, and that they're going to recoup about $1 million over the 6 years in payments for downside. But they're only estimating 2,600 additional transplants. The reason that they have net savings is that they feel each transplant's going to save, you've seen those figures, a substantial amount of money, at least $100,000, which is probably an underestimate over the 10-year period. And that's how they come up with that. But this model obviously is not set to have big impacts. These are the rationales for the performance scores. I just want you to have them, whether you agree with them or not. They do go through great detail in these rules, and I want to credit them for all the detail that they provide. For transparency, they intend to publish results on a public website. They want the transplant center to publish what criteria, so patients know what's used to add patients to their wait list. And this is a big one. They want, on a monthly basis, I've capitalized it, patients need to be informed of how many times a kidney was declined for them on their behalf. Transplant centers, if selected, must submit a health equity plan, optional year one, but mandatory payment year 2 and beyond. That's health-related social needs in the last bullet at the bottom. Dialysis centers will have to do this next year as part of the QIP, as Vicki and others know. Interestingly, some Medicare payment waivers, they're allowed to do this in these models. So transplant centers could enter into relationships with other partners. You see them in the third bullet, and they could share with them in risk with this model. They also are allowing transplant centers to subsidize patients in whole and apart for immunosuppression, and they're going to provide anti-kickback statute safe harbors. This is a new one for me, that second major bullet, communication devices. They're going to allow, if you will, cell phones, pagers, other things to be provided. Transplantation exists for the ESCO and the KCC, mental health services, and 90-day post-transplant home care. There's rather extensive monitoring they're going to employ. And they did talk about a new IOTA learning system at the conclusion of the ETC model that may replace the ETC-LC. And they intend to publish all results on a model website using what I've showed you below, the performance scores, identifying each IOTA participant. They're going to allow for review by the participant. They will share this data with IOTA participants, so they know what's happening, and it'll be done on a quarterly basis. And Medicare patients must be notified of attribution. They may decline data sharing, but not to participate. Last but not least, they requested information on these topics, inclusion of a health-related quality of life in the model, and access to wait lists, both from the perspective of the transplant hospital and kidney transplant and dialysis patients. And I think that is it, Carolyn. Let me see. How do I stop sharing, Carolyn?
Up at the top.
Oh, there we go. That's what I wanted.
Perfect.
I wanted just to get you guys on so we could talk. And I'll leave it up if I need to pull that. Is that okay if I need to pull it back up? But
Yeah.
I hope I
That should
didn't overwhelm folks. There's a lot of information there, but you'll have that whole deck, and it beats the heck out of reading 384 pages.
Thank you so much. So does anyone, there are a couple questions in the chat. Vicky, if you want to unmute and ask them, just to make it easier. And then if anyone else has any questions, you can raise your hand or put it in the chat as well.
I just, while you were talking, Dr. Howard, and thank you so much. I know you have extensive experience with payment models and have spoken on this for years, and all of your background working with Fresenius and these large dialysis organizations, and as well as the chains and KCC model work that you do now really helps us, because you digest all of this and make it very manageable. So we appreciate you coming on and sharing all that with us. One of the questions I had about those DSAs they made, are they going to then take performance factors beyond the DSA to pick a transplant center, or is it just going to be a randomly assigned transplant center in the DSA?
Well, if a DSA is selected, Vicky, they said what they're going to do is they're going to every eligible, I know I'm dragging that out, transplant center in that DSA is going to have to participate. Okay. What they said, and I must admit, you probably have to be a statistician to understand all this, and I am not. I will share with the group. My wife's a biostatistician, and one of my sons is a data scientist, so I do lean on them to help explain some of this to me. But they do go through extensively this use of these 8 census divisions. This was a point of contention because a number of people felt smaller transplant centers were going to be unfairly treated with this model. Whether they're going to succeed, Vicky, in what they said they're going to succeed in doing, I don't know. I don't think I have the expertise, but I wanted to put that in there so you all knew they were cognizant of that, and they are trying to do that by using census divisions to help select DSAs, but they do emphasize it's going to be random. But that, I guess, is where the targeting comes in. I hope did that help a little? I don't know if it's going to work, Vicky, but that's how they want to balance out small and large. But if your DSA is selected, you're in, as long as you qualify by being an adult, as they define an adult transplant center.
We can take another question. I see somebody has their hand up.
Yep.
Colleen, go ahead.
You might need to unmute yourself, Colleen, but everybody's able to.
Thank you so much for hosting this important topic. Dr. Howard, do you have a sense of when the timing of that notification may happen on if you're in the DSAs that are in or out? And then I have another question about public comment period.
Yep. So, yeah, why don't you ask your second question, because it's going to impact my answer to your first question.
I've been combing the public comment so far. I've been unimpressed with the quantity of public comments, and I was just curious if you knew that public comments were coming on the way from our associations and whatnot. I'm particularly interested in giving feedback related to the organ offers, that monthly report that's proposed. I think that's pretty onerous, and while I can see value in some sort of report and information to patients, I think I'm a little nervous about that level, that intensity. And I do want to give some good feedback on that.
Yep. So we are in the 60-day comment period now, and the deadline for comments is going to be July 16th. So we are the 9th. So basically it's going to be a week from today. It's 5 p.m. Eastern time. comments must be in. In the rule, they give multiple ways to comment. It can be via email, it can be through mail, regular mail, it can be through certified mail. But the postmark, if it's mailed, most people obviously are going to do by email, do an electronic submission because it's a click of a button, it's easier. But that's in the very beginning of the rule. Vicki, perhaps that's something you guys can provide. I know Kelly can help with that. Kelly Brooks, Vicki, so we can get that out. That should be shared with everyone because individuals can make comments. So that's the 60-day comment period. What has to happen, Colleen, and these are great questions, very important, is they have to issue a final rule. This is not a rule yet. This is a proposed rule. Although I've never seen them do this before, there is the possibility that they could elect not to publish a final rule. They could say, we're going to hold this. I should step back. The one time I saw that happen was with COVID, when they released the ESRD treatment choices model. They delayed the start by a year of that. It was supposed to begin in 2020. It came out in 2019. And because of the public health emergency, they pushed it back by a year. So first we have to get a final rule. Generally, I can tell you after comments come in, CMS can take another 60 days to enter the final rule. I'm just guessing here, Colleen, but so now we're pushed back to September before we would see a final rule. And if they do publish that, I would imagine that selections would come out within 30 to 60 days after that. So you're looking at the earliest mid-October, November for notification. The one last comment I'll make, Colleen, is I think your concern is spot on. Many others had that same concern with that particular aspect of the efficiency, organ acceptance and notifying patients on a monthly basis. I think as we get to a week from today, I personally believe you'll see an explosion of comments coming in. I know I've been privy to several organizations knowing that they're going to submit. I just don't think they've come in yet.
Thank you so much.
My pleasure. Vicki, are there others in chat? I know there were several, or anybody can, certainly identify and ask.
I had asked Dr. Howard while we're waiting for other folks to come off mute or identify a question. It's particularly, is it counting only Medicare fee-for-service patients in this population? I mean, how do they regulate this with like the Medicare Advantage programs, things like that?
Yeah, that was I belabored that, but let me go over that again, Vicki, because that is important. So what they wanted to do for numbers, if you will, to help scores, to give transplant centers as large a population as possible, they basically said, we're taking all comers. We're going to take Medicare primary fee-for-service, Medicare secondary payer, Medicare Advantage, which you all know is the estimates I've seen has about 50% of the population on dialysis now. It just keeps growing. Although there's some interesting articles, there are those who feel that was an abject failure. But that's another topic. And commercial they're going to take. But when it comes to making either a positive payment adjustment or negative, Vicki, this is the crux. They're only going to use Medicare fee-for-service and Medicare secondary payer. They're not going to use, okay, so that's how they're going to deal with it.
Yeah. So
yeah, it's
so
kind
they'll
of
use
subtle.
Everybody as it's weird. They'll use everybody as a population, but then they're only
everybody's a population. They feel they're helping because they're going to boost numbers with that. But I think obviously it protects them with positive payments. And this is frustrating because I know with our practice, we had a large commercial population. I practiced pre-Medicare Advantage, and a lot of our transplants were in our commercial population. But, we took the approach, Vicki knows this, you all don't. I was a mid-sized nephrology practice, about 10 providers. I really embraced transplant. When I trained cyclosporin, it just came out and I just embraced it. There were no transplant nephrologists. I guess I was an early transplant nephrologist. But when I left my practice, we had 300 to 400 transplant patients we were providing direct care for. So our approach was everybody potentially is eligible for a transplant, and we had a preemptive rate of about 10%. But in any case, yeah, that's what they're going to do. I think I just saw something flash up, Vicky.
Yes, there was a new question in the comment section. It says, is Clarity known for the notification of patients on the wait list if it will be a cumulative sum of organ offers per patient or just within 1 month's worth of time per patient?
Yeah, that's a great question. And I apologize. I'd have to go back and read. My sense from reading that it was just over that month what they were looking at, what came in, but I may be misquoting that. I may be misquoting that. Oh, there's a great question that just came up. Joseph, I can see you, and I think it was your question. Are there penalties for noncompliance? Some transplant centers may think of this as a blessing, but yes, they can basically kick you out of the program, which some people may think is a blessing. Oh, great. Okay, I'm out. So, yeah, no, there's no monetary penalty, though. There's no monetary penalty, no sanction or anything. It's just that, you didn't comply, so we're removing you from the program. That's how it's listed. And Carolyn, you've got.
Yeah, so on the topic of criteria disclosure, we have an application actually through the IPRO ESRD network that has now all of the transplant centers in our 13 states inclusion criteria or medical exclusion criteria, so 50% of it. Is a program like that, does that fulfill public transparency of criteria, or do you think it would need to be in a different location? Or what are your thoughts on that?
No, that's actually, I would think that may be spot on and may actually work quite well. That may work quite well. Carolyn, this would be a great opportunity too, just to get that query into CMS during this time period. I will tell you one thing Vicky, you've heard me say this before. One thing I will credit them, when they put the final rules out, they will answer every query that they get. I mean, the final rules can go on for twice the number of pages, but credit given where credit's due, they will answer every query as long as it relates to the rule. So that would be a great opportunity to get clarification. And, because obviously, given the sheer size of IPRO, it's entirely likely if this model goes forward, there will be DSAs within IPRO that are going to be tapped.
Definitely.
You're just too large. You aren't too large. You're large enough. You're going to have DSAs selected.
And I think that the more they see a comment, the more likely they are to really research and find out, right? I mean,
yes.
in terms of
they put a lot of time into this.
Right. They've adjusted rules based on, because I know the transplant centers aren't used to this, but they've adjusted payment rules if they've gotten enough pushback and comments about it. They have listened, and it just takes a pretty loud voice for them to kind of switch their options. But it seems like the louder the voice, the more they'll switch.
Vicky is correct. They have modified rules based upon, particularly if they have several commenters. Colleen, the area that you brought up, that's a great example. You will not be alone, I can tell you, in offering those concerns. Others will as well, and that may lead to modification of that provision. So do not think that your voice won't be heard.
I appreciate that. And while we haven't had that much experience, I'm coming from a transplant center in the payment model, we definitely give public comments on UNOS policies, and those are heard and reviewed and carefully. And and have been incorporated and meaningful. So
Mhm.
the public comment process is so valuable, and I'm so grateful to have it, and I hope everyone has the ability to use it.
Perfect. Well, for the sake of time, I don't see any other questions. On behalf of the IPRO ESRD network and all of the attendees, we want to thank you, Dr. Howard, for joining us today. You've definitely established yourself as a subject matter expert in this field through your different work in the KCC and the ESCO program. And then all of the study and the lecturing on all of the voluntary and involuntary models, QUIP and PPS. So we are very grateful that you were able to come on and provide this session to our transplant centers in attendance. For all of attendees, the presentation material is already scheduled to go out into your inboxes on Thursday. So you'll be receiving a copy of this shortly. I can stay on to answer any questions if there's anything else that any discussion that needs to take place, but we just want to say thanks.
Okay, Carolyn, thank you very much. Should there be questions, I'll be happy to, you all can, Vicki knows my email well. You have it, Carolyn. You'll love that kidney doc, my wife's creation. The statistician. But please, I'll be happy to try my best if questions come up when people get the materials. But you'll have all that extensive background material too at your fingertips. So.
Well, thank you. Thank you for your time, and everybody get your comments in. You've got another week, right, Andy?
Yeah, another week.
All right. Thanks again.
Bye-bye now.
Bye.